All right, good afternoon and welcome everyone. Thank you so much for taking the time out of your days to join us for this webinar today. My name is Chanel Moore and I'm the Peer Support Coordinator here at Lung Foundation Australia. Before we start today's presentation, I would like to start by acknowledging the traditional owners of country throughout Australia. And in the spirit of reconciliation, we pay our respects to them and their cultures, their continuing connection to land, sea, and community, and to elders past, present, and emerging. Now, today we are talking about intravenous medication and pulmonary arterial hypertension. And I would also like to thank our supporters in this webinar series, Janssen Pharmaceuticals. So today we're very fortunate to have 4 speakers with us. So we have a fantastic expert panel of people who are going to be talking to you today and also available for our live Q&A session. So before I do go ahead and introduce our speakers, just a couple of housekeeping points. Firstly, we will be doing a Q&A session, so that means you have the opportunity to submit questions that you have via a Q&A box, which you should see on your screen. So please do go ahead and submit those questions as they come to you. It won't interrupt the presentations at all, but please just bear in mind that responses to your questions will be of a general nature only, and to please do check in with your treating healthcare team to gain that specific advice for your lung health and to discuss your specific needs. Now, the webinar will be recorded, so if you do need to leave at any point, you will be able to access all of the information discussed at a date and time that suits you. So we will notify everyone via email who has registered for the webinar when that recording is available. So today we have our 4 speakers. So we have Dr. John Feenstra, Dr. Michael Trotter, and Kerry Lee Driver. And so they're all joining us from here in Brisbane from the PH Pulmonary Hypertension Clinic at the Prince Charles Hospital. And we also have Tharuka, who is our patient representative, who is going to be joining us to share his lived experience. So we'll be asking Tharuka some questions, which he's going to answer, and then you will also have the opportunity to ask him some questions during that live question and answer session. So thank you to our wonderful speakers for taking that time to come and talk on such an important topic. And what I'll do now is hand over to you. We'll start off with John, Michael, and Kerry Lee, if you'd like to share your screen and share your presentation and chat with everyone joining us.
So, epoprostenol, our experience here at the Prince Charles Hospital. We've got Michael Trotter with me also this afternoon. So we're specifically talking about Group 1 PAH, or pulmonary arterial hypertension, as you can see through their idiopathic, hereditary, drug, and also connective tissue disease connected. So we use IV epoprostenol in amongst our evidence-based treatment algorithm. Obviously, a patient is referred to a PAH-specific centre and undergoes a number of investigations, and typically the final investigation will be at the right heart catheter to determine their pressures and give us quite critical data, particularly looking at patients' pressures and cardiac output. From that, then we can determine a patient's risk of their pulmonary arterial hypertension and whether or not we go on to oral therapy alone, initially by itself or in combination. And if we deem someone who is a high-risk patient with functional class 4 symptoms, that's someone who's extremely short of breath, even with limited tasks around the home, whether or not we need to consider IV epoprostenol from the start of their therapy. So what we're looking at in patients with risk is a number of things when we see the patient, not just the right heart catheter, it's also their history of symptoms, how rapidly they've developed their symptoms. Have they fainted, for example? That's a sign of of severity, how far they can walk when they do the 6-minute walk test prior to us seeing them. So it's a number of different things that we put into. Are they in the red zone? Are they in a green zone, saying they may be safe to go on to oral therapy initially? Presently in Australia, we have drugs that can affect 3 of the pathways, and prostacyclin represents the 3rd or final pathway through either IV therapy or now we do have an oral therapy that we can use to target that prostacyclin pathway. But even though we've got this oral therapy now available, the intravenous therapy still plays a critical role in patients that we deem high risk from the initial assessment. So that may be someone who's come in with rapid progressive symptoms and has had a fainting episode, and or their walk distance is very short with bad hemodynamics on a right heart catheter. The other time that we have discussions about IV epoprostenol is when someone who may have been commenced on upfront oral combination therapy, you know, for example, bosentan, macitentan, ambrisentan with sildenafil or tadalafil. After a period of time, maybe 3 or 6 months, they haven't responded to therapy as we would have liked, and they may still have intermediate risk or high risk numbers that make us concerned to think about IV therapy, or even in situation if the patient is deteriorating quickly, we consider referral for transplantation. So why is IV epoprostenol important? It's the only drug on the market that has actually seen mortality benefit. So you can see that this study was done in 1996. It's a very short study over 3 months, and as you can see in the IV epoprostenol arm, there were no deaths in that period of time compared to 8 deaths on IV EPO. There's been meta-analysis on several studies, randomized control studies with IV epoprostenol, and again it shows a relative risk reduction in mortality, again by 70%, which is quite dramatic compared to oral therapies that are on the market. Why we talk about epoprostenol in clinic for patients that may not be progressing as well as we'd like on oral therapy is that we know that if we start IV epoprostenol electively, so that means we've discussed the patient, the pros and cons of going on to therapy, they do better in the long run, as we can see here in the yellow line, than someone who has been deteriorating and may present very unwell with right heart failure in hospital. They don't do as well if we've planned to start this medication at a much earlier time period than waiting to someone who's very sick. Olivier Sitbon has published data, and there's more data coming from the French group, showing that patients that present very unwell, functional class 4 with very, extremely short of breath and can't, maybe in right heart failure, they're in hospital, do much better if we start upfront triple therapy. And that's when we also be discussing the oral therapy plus the use of IV epoprostenol. And we can see that there are significant gains in patients that have been so unwell going to, good functional class, and that's these purple bars here. So that means they're getting shorter breath, not with activities of daily living, but maybe with a hill or a stair or something more strenuous than being short of breath doing just normal activities around the home. He's now out to about 80 patients now with published data in the last month, showing, again, this approach with people that are very unwell. IV epoprostenol is key for having patients living longer with this disease and quality of life. Now, presently in Australia, we have a listing for it for patients with idiopathic or PAH, that group 1 or connective tissue or functional class 3 and 4. As of March of this year, it has been approved. Previously, it was only monotherapy with combination with sildenafil or tadalafil, which works on a second pathway. Typically, when we have patients on IV epoprostenol at the Prince Charles, we have people on triple therapy, and companies like Janssen or Actelion help us provide the third drug like macitentan or bosentan compassionately. So why is epoprostenol requiring an infusion intravenously, and it's a pump that needs to go for 24 hours a day? Is that the drug itself, even though it's very potent, only lasts for about 6 minutes in the bloodstream once it's injected into the human body. Therefore, patients will need permanent access, and this typically is done while they're in hospital, either through a PICC line, which goes through the arm, or a central venous catheter, or a Hickman's line, which goes in, as you can see in this diagram here, tunneled under the chest wall down into the greater veins inside the heart. So this pump is attached to the person through a line with it, and it's continuation of delivery of this medication over a 24-hour period. Obviously, there are downsides. There are issues with, we do have issues with pumps, alarms and lines, but things that, you know, our nursing staff and the patients work through to fix. Itself, the drug, again, why we use it as a electively third line, is that it does have a number of side effects that can affect people's quality of life, and that, you know, can include nausea, vomiting, headache, flushing. A unique side effect with this medication is jaw pain. So every time someone takes a bite of food, they can get a pain at the start of the meal, and that may last while the time that they're on the medication, or it may subside as once they get to a steady dose. Obviously, when we've got this line in, there are issues with infection. There can be local and systemic, and sometimes we need to look at replacing lines and replacing them with a PICC line as a temporary measure. The issue is, if this drug suddenly stops, people can have abrupt increase in pressures and shortness of breath, and we have protocols in place with the Queensland Ambulance Service here for our patients if they do have problems or disconnection or abrupt withdrawal of their drug. So IV epoprostenol is not like other drugs where you just take one set dose of a medication. It does vary from individual to individual with regards to toleration, and we try to aim to have a dose between 20 and 40 nanograms per kilo per minute. Our average in Australia is about 27. At the Prince Charles last time we reviewed, that's about 23. So over time, the medication is titrated upwards to the patient's tolerance. The reason why we need to increase the medication over time is a process called tachyphylaxis. So over time, there is a diminished response to successive doses of a drug, making it less effective. So over months or even years, we do look at increasing the drug for each patient over time. So, you know, so with this, you know, the optimal dose range for a patient changes, and sometimes it might take us 6 months to get to that sort of optimal dose. We here review patients on IV epoprostenol every 3 months, and then we will consider up titrating the dose if we think that tachyphylaxis is suspected. So decisions on that will be, what are the patient's symptoms? Has there been any deterioration there? Has there been any adverse events, or has there been a decrease in their 6-minute walk test? Or sometimes we do look at reassessment, hemodynamics, and repeat the right heart catheter. And if we're concerned there that things are heading in the wrong direction, looking at increasing the dose of the epoprostenol at that time. So we can just see here a couple published from the French and the American group over time, you know, the dose escalation with epoprostenol, again, you know, would be in keeping with our practice here at the Prince Charles Hospital. So finally, here we're a referral centre for the other PH centres in Queensland for IV epoprostenol. We do have a shared care approach with other centres when patients do require IV epoprostenol. For example, we've got a patient as far as Cairns that we manage with the doctors in Cairns. We have about 35 to 36 patients now, and you know, Tharuka will be talking to us again this afternoon, but you know, we've got an established transition clinic with the Queensland Children's Hospital. We do 2 joint clinics per year, and there are patients that are on IV epoprostenol through their adolescence or childhood, which transition to the adult service here at the Prince Charles Hospital, and we take on that role between Michael and myself for those patients. So that was a brief introduction to IV epoprostenol. I hope I got across the importance of IV, where it sits in the treatment algorithm. And obviously Michael and I will be here to take questions.
Can I start by asking a question, John? So, I think he's not expecting this. So, you told us that probably intravenous epoprostenol has probably got the best survival benefit of all the pulmonary hypertension medications we've got. Why don't we use it in all of our patients who we diagnose with pulmonary hypertension?
So I think, look, again, we know that there are the combination therapies, particularly with the AMBITION study. We have a look at Seraphim, and also now with Griffin, that there are going to be patients that are going to have good survival on oral therapies without the need to use intravenous therapy. I think the problems of the delivery is the reason why we're not using it as frequently.
Yeah.
Because of the side effect profile and also having a permanent line in and a CAD pump. So again, I think it's going to be reserved for those patients who are not doing well on combination therapy, if it's double oral or triple oral now, or patients that are particularly the high risk candidates when they first come in and see us.
Yeah, I tend to agree. You know, going on to this treatment, it's a pretty big deal having the line put in and, you know, living your life with a continuous infusion running, with the kind of stress of keeping it running. You know, we've got to make sure that the disease process we're treating is worth the inconvenience and the medical side effects and problems that we sometimes see with the line, and get that kind of risk and benefit kind of weighed up appropriately. Now, some people, as John says, get a good response with the tablet therapies, whilst other patients, you know, will have features within their clinical history and their clinical profile, which means that we should consider using this medication in those circumstances. And that's our job, to weigh up those risks and benefits and pros and cons and pick the right treatment for the right patient.
Great, thank you so much for that, for both of you, and also asking an early question to
getting there early. Yeah, sorry.
I'll just now hand over to you, Kerry-Lee, if you'd like to chat with everyone today or share any additional information that you might like to.
So probably just moving along from what John has discussed and also Michael supporting that, just some things from a practicality perspective that certainly here at the Prince Charles we address, and things that we work through when we're considering somebody to commence this therapy. Again, information and choice for the patient and their family, and just talking about those pros and cons and risk and benefit, if we have the luxury of time to be able to do that with patients. Like Michael alluded to, it is a very big decision to undertake, to commence this therapy. It's a commitment, and it changes your life in regards to being attached to a continuous infusion and management of an intravenous line as well. So that's something that John and Michael will talk through with patients in clinic, and us as nurses will also have time with them as well. We discuss the intravenous lines that we would opt for depending on the patient, whether it be a PICC line or a Hickman line, but again, a continuous implanted line that requires care and attention and has barriers in regards to lifestyle. So submersion in water, swimming, that sort of thing. All of those things can be impacted on all of a sudden having the line implanted and a pump attached. The pump itself weighs about 400 grams, and it might not sound like much, but once you've carried one of these pumps around for part of the day, you can start to appreciate the impact of somebody actually having to do that 24 hours a day, 7 days a week with no break from it. So that, again, is something that people would need to adjust to. We consider the person themselves and the support that they might be surrounded with or might not be, and just potential factors that might impact on their ability to self-manage and prepare the medication for the pump. It does come with a reasonable preparation regime. So with our teaching and learning, we find out as much as we can about the person so that we can adapt our teaching to get the best outcome in teaching them how to self-manage with pump preparation. and what support they have, so that in the event of them having something happen or needing more help at home, that they've got somebody at hand that can actually be a backup person to help with the logistics of pump preparation and pump problem solving as well. John mentioned in regards to just a patient that we have in Northern Queensland. And so from our perspective geographically, that hasn't been a barrier for us in regards to offering this therapy to patients. We have patients all over Queensland and Northern New South Wales on this therapy. And we adopt many different ways of helping manage them, certainly while we're teaching them as an inpatient, but also our follow-up and our support from medical and nursing perspective beyond the inpatient stay, so that even though they're a distance away, we have lots of different ways that we can support them. And that involves liaising with kind of their primary care practitioner, if we're doing the shared care model, liaising with their other home team at another hospital, so that these patients are very well supported regardless of not being geographically located close to us. The time perspective, I just put that in there for mentioning, and that goes back to the slide that John had in regards to the low, intermediate and high risk patients. So sometimes we do have some lead up time in regards to talking to people and their carers or their family members about we're heading towards or thinking about initiating this therapy, and time to teach and help them adjust to the concept. Other times we don't have time, and somebody will come into hospital that is incredibly sick. They're in the red zone that John showed you, and we really need to start this therapy immediately. And that obviously has implications for the patient with their adjustment and also their teaching and learning. I've mentioned about the teaching and learning approach and just how we adapt that. Sometimes people come with dexterity issues, an ability to handle the equipment. Other times there's just different approaches we need to take in regards to other smaller disabilities to be considerate of. And another thing that's talked through quite intensively is around expectations and outcomes, so that we try to be as realistic as possible, so that when we start this therapy, we are forewarning the patients and their support people that, like John said, it can have a reasonable side effect outcome, and just might not see any immediate results in regards to as we're titrating until we start titrating up on the dose. So every person has a different response that we found. So when we start the intravenous medication, it will, from our perspective, it's an inpatient stay. That inpatient stay can, the length of time can vary depending on the patient and their learning needs and their side effect occurrence when they start the medication. So we don't put any timeframes, we don't have any expectations, we take it very, very individually. Our focus is establishing the patient on the therapy, minimising or managing the side effect burden, but also making sure that from our perspective and from the patient and the carer's perspective, that they feel that when they leave hospital that they've been, they're well versed in the teaching and learning that they've had, and they feel confident to self-manage their intravenous line and their pump when they return home, and when they're not in the kind of the support and comfort of being in an acute hospital environment. Adjusting to the line and the infusion pump, teaching patients in regards to how to have a shower, how to do different things. Well, they're now connected to a pump. So a lot of that stuff we often don't know ourselves. So that's when we will ask patients if they would like to be connected with another patient that is on the intravenous therapy. Some patients like to, some patients don't, or some patients would like to just get established first, and then when they feel a bit more confident, then they, for whatever reason, will ask us to if they can connect with another person. And I think that's just making a mention here. This is that's the beauty of having the peer support program established through Lung Foundation, is that patients can make those connections through that way as well. It's learning a new skill for patients. So we teach patients from a very, kind of a young age, right up into, kind of middle age and beyond. So everybody comes with a different background and life experience. So it is learning a complete new skill. And when we start teaching, it's a look of a look of horror and trepidation on their faces when we show them all the equipment and we talk through about what they're going to learn. But by the time we've kind of taught them to a safe level and they can go home, they're very, very confident in different patients in the way that they have learned incredibly well in managing that new skill. Our focus on the teaching is about demonstrating clean and safe medication preparation, minimise infection risk, and also managing the pump and problem solving through things that might happen. We provide things to support them as much as we can from a distance, and like John said, we have things set up in place with liaison with Queensland Ambulance Service for an alert connected to that patient should an adverse event happen with the line or the infusion whilst they're at home. So that's set in place and that works incredibly well. And we provide other things that can help support the patients if you know, they're living the life that they need to live, either, you know, in the workplace or at home or for travel. We'll do what we can to support them to do whatever they want to do whilst they're receiving this medication. So, and as I've mentioned before, we'll follow up them up when they're at home as much as we can and as much as they need. We've done telehealth into other hospitals to follow up on teaching around preparation of the infusion and pump when patients have been having a problem with really good outcomes there. And that was for a patient that was up in North Queensland as well. So probably just to finish, important points. I think I don't think we can ever just understand the degree of adjustment that patients go onto this therapy go through. And I think for some of our patients, we see they adjust incredibly well, and other patients take a longer time, and we're very aware of that. And also not just themselves, but also their family members, their children. They're direct people that are around them as well. It just doesn't impact the patient with the line and the infusion. It impacts the partner that's sleeping in the same bed and is waking up to the alarm that the pump makes when something's happened to the line. The psychosocial factors, so this is something we're very cognizant of in regards to, and we try to keep a very good eye on these components when people do come to clinic and have reviews with us in regards to the anxiety component that can be associated with having this therapy, and being responsive to either a pump alarm or having commitments to change the infusion every 24 hours. And also, some patients can experience just some depression associated to adjustment. Relationships and intimacies, this is something, again, that we work with patients on as and when it's appropriate, and that can be often a discussion between myself and my colleague Jennifer in regards to when we're talking to patients, more so the younger ones, in regards to how that impacts on their life, having a pump connected to them. Work and employment, so this is something that where people can and do continue to work and adapt the pump and the infusion into that life. Improvement in lifestyle. So, the goal of this therapy is to improve people's quality of life, to improve their functional ability, and hopefully with minimal side effects that can be manageable and tolerable. And so improvement in lifestyle, are patients able to participate in activities with their children, feel well enough to do things that they hadn't previously been able to do, travel. Travel, certainly we encourage all of our patients, of course, pre-COVID, when travel was a bit more able, we have patients that travel with this therapy either nationally or internationally, and we support them to do that. And that again contributes to the reason why we're initiating this therapy, so that people can continue to live the life that they aspire to do, and they have an improved quality of life as well. So that's all from me. Thank you.
Great, thank you so much to all of you for speaking and providing such a thorough overview of intravenous medication, and it really does make you aware of what you were saying, Kerry, around learning that new skill, and how important it is to go through that education with people, and and how that self-management is really important. So no doubt your words really resonated with a lot of people watching. So thank you for addressing that. Now, I'm very pleased to introduce our patient representative, Tharuka, and talking about his experiences. So what we're going to do is ask a few questions and invite Tharuka to share a little bit more about his experiences. But if you do have questions for him as well, then you can submit those through that Q&A box, and we can address those during the live Q&A session. So Tharuka, I guess first of all, thank you again so much for doing this, but perhaps we can start off by you being able to introduce yourself and perhaps sharing with everyone watching, if you're happy to just share how long you've been living with PAH yourself.
Yeah, definitely. So like Chanel said, my name's Tharuka. I am 23, so I'm somewhat young, slowly hitting maturity, but so I've had PH since I was 11. I believe that's when I was first diagnosed, and a year after that, I was just on tablet medication. And then at the end of grade 7, which would have been 2010, I got put onto the intravenous medication. So from about 12 years old up until now, being 23, I've been on the infusion. And I believe, in my experience, I have definitely experienced a lot of benefits from this, but I do also, like the doctors did explain, I have experienced some of the side effects, but I think from the amount of good experiences I've had being on this, it definitely outweighs any of the negatives that I've personally experienced. There was something else I wanted to mention, but I can't remember at the moment. So if you have any questions, Chanel, feel free to ask away.
Okay, all right. Well, look, I'm sure whatever you were thinking will come back to you. It always does at the strangest moment. But yes, we have got a few other questions. I guess, you know, are you able to share with us what day-to-day life looks like for you, if you're able to paint a bit of a picture with intravenous medication?
Yeah, so on a day-to-day basis, there's not particularly a whole lot you have to do in terms of maintaining the medication. So obviously you change it every 24 hours, which is something I do each morning right before I go to work. But then up until the next day, there's nothing else I really do. In saying that, with the maintenance of the pumps itself, every week I'll switch the pumps with the spare one I do have. As well as that, I'll change one of the connecting lines and also the bung that's attached to the Hickmans that I have. But besides that, it's pretty straightforward. And I guess on a day-to-day basis, you just make sure it's clean. So when you have a shower, just make sure there's no ooze coming out. If you do notice anything, taking the right steps to speak to your doctor and maybe get some kind of antibiotic or to get it swabbed or something to figure out what the next step is always the best way to go. But in a general sense, there's not a whole lot of day-to-day maintenance, and it doesn't really impact your life. It takes, for me, sorry, it doesn't really take too much out of my day, maybe like 2-3 minutes just to change the actual cassette over, and that's it.
Okay, well, thank you so much for being so open and sharing that. I wonder if you, you know, you've mentioned since 11 when you received that diagnosis. So over that time, have there been any challenges that have perhaps stood out for you and how you've worked to overcome those? Is there anything that you could share with us around managing any challenges?
Yeah, definitely. So the biggest one I would say is just infections. But going through high school, when you're constantly in the sun and sweating, that would pose a big risk in terms of infections. And if you're not taking the right steps to keep yourself clean, you're going to have that increased risk. But as long as you're taking those right steps, you should, for the most part, be okay. And dealing with it is kind of, you have to just take it as it goes. At the end of the day, it's not the worst thing. There's ways to cure the infection, and then from there, the doctors are able to figure out what the next step is for you, and you just have to keep going. That's the biggest thing. that I could really tell anyone with this. And if they're considering going on it, that's the biggest thing, is just to keep going. Things will get better. You just have to stick with it. Besides that, the other big thing is walking around with a line that maybe people can see if you're wearing a backpack. It is brought up in conversation quite a bit. People always just asking, why are you wearing that backpack? Or just having, general curiosity. I feel like that's more of a personal, or you handle that in a personal way, which feels comfortable for you. I personally, when someone asks me, I don't tell them straight away unless I'm comfortable in who they are or I know them a bit. So usually I'll just tell them I feel like wearing a backpack, and usually they won't ask any other questions besides that. But when it comes to friends, I'll always be open, or if it's someone that I'm comfortable around, I'll tell them that I have to wear a pump, and that's usually the end of the conversation. They don't ask too much. They're just a little bit curious, which is understandable. Besides that, I wouldn't say there's too much else. And if it does come to a point where people are constantly asking questions, don't ever feel like you have to tell them what's going on. It is a personal thing. So the only other thing I can say is just walking away from that situation, not letting yourself just sit there and, I guess, be attacked like that or pushed like that. And if you are with friends or family, usually someone will step in and kind of get in the middle of that and stop it and protect you.
Oh, thank you so much. Look, I think that's great that everyone watching was able to gain that insight into how, the kinds of questions that people will ask you and how you personally cope with people asking about why you're wearing that backpack and so on. And I'm sure your words of wisdom to keep going will, and to take each day as it comes, I guess, will be really inspiring for other people living with PAH. So thank you. I can see that we have had a few questions come through. So no doubt there are some in there for you as well, Tharuka. So what we might do is go to the Q&A session now, and I'll just direct those questions through to either or all of you as they come in. Now, we have had a couple of questions actually that are around the approach to intravenous medication in different states. So I'm just wondering if you're able to provide a bit of information to the person who asked. So one person has said, do patients in Queensland have to pay for the upkeep of their pumps? They're in New South Wales ACT, and they do pay a fee each time a service is required or a malfunction. Are you able to shed any other guidance or information around that?
I can't talk about other states. All I can say for us in Queensland, all the pumps are funded through the Prince Charles Hospital, and there is no charge for patients if there is malfunction or any issues with the pump. We get them serviced on site, or if there's ongoing issues with a pump, we send it back to Smiths, the manufacturer. So I don't know what happens in other states with regards to the pump costs.
Okay, thank you. And look, please do reach out to our information and support centre, anyone who's watching, to have a chat about your individual circumstances as well. And we can, the team can certainly have a chat to you and see if they can connect you with any services that might be able to provide more information as well. Look, we have had another question come through, and this time I will put it your way, Tharuka. This person has just asked what it's like coping with practical things like showering, getting dressed, and how does all of this work? Are you able to, I guess, provide a bit more information about how you manage those sort of day-to-day practical activities?
Yeah, definitely. So with sleeping, it's fairly basic. I just put the pump next to my pillow or maybe slightly under my pillow, and for the most part, I don't get tangled in it. for showering, it's quite similar. I have these little plastic hooks outside the shower door, so I just hanging it up there and then hop in the shower like normal. And then what was the next one? Sorry, getting dressed. For me, it's like normal. You just put your shirt on and it covers everything. You're fine. I guess the other thing is with the pump, people wear it in different ways. For a couple of years, or for most of the time that I've had the pump, I would always wear a backpack. So I put it in my backpack, put the bag next to me, put my shirt on, put my bag on, and that would basically be it. But recently, me and my mum came up with this little pouch thing that I just put it in, and then I'm able to strap it around my leg. So then that way I avoid the bag questions, which was personally a big thing for me, but it's just like getting dressed like normal. It's not a huge deal, especially because the pump is quite small. You don't really, I guess after a while, you don't notice it. It's just part of who you are now. So yeah.
Oh, thank you. Thank you for sharing that. And, you know, the new approach you've taken to avoid the backpack as well. I'm sure that will be very helpful for people watching either now or in the future. Look, we have another question as well, which I might hand over to John, Michael, or Kerry Lee. So this person has said what actions you would take to help manage side effects. So I know you mentioned during your presentations around potential side effects. Are you able to expand a little bit more into how you would work with people to help manage those?
I can take this one if you like, John. So first up, you know, our patients have got to live with this medication. So we don't want to increase the infusion rate at such a degree that it makes life unbearable. You know, that's not something we want for the people living with PAH and living with this medication. So really the increase in the infusion rates limited by the side effects. So we don't want to increase it so quickly that the side effects are intolerable. And then really it depends what the side effect is. You know, we've got medications really to deal with all the different things. So headaches, paracetamol, jaw pains, aches and pains, usually paracetamol-based medications. Diarrhea is another common thing that we sometimes see, and we can use medications to slow the gut down. But in general, if the side effects become intolerable and become really dreadful, what we would usually do is maybe just back off in the infusion rate, just lower the dose slightly, let our patient get used to that lower dose, let the side effects subside before we go up again. So it's really two-pronged attack: not increase, not give so much medication that life's miserable, reduce down before increasing up if necessary, and then using specific simple medications to try and work around all those side effects.
Great, thank you so much. And before we go to the next question, just wondering, Kerry, if there's anything else you wanted to add to that question also?
Well, probably just to note that, again, every patient is different, very, very individual. And so we've got a suite of things that we can do to help minimise the side effect burden. And we just work very closely certainly with all our patients in just getting the right mixture for them. So it's having their connection to us and contact with us that often helps facilitate a good outcome in that regard. And certainly when we receive the calls and we talk to Michael and John about what the patient's experiencing and how to best manage that. So.
Wonderful, thank you for adding to that. And look, we've got one more question here, and this might be another one for you, Tharuka, around working with PAH. If there's any information you can share with everyone watching around how you manage the medication as well as working.
Yeah, so the big thing that I would say to do is always notify your manager or whoever you work under, just so they're aware, and if something does happen, that they know what to do, which is usually just to call the ambulance. But then besides that, on a, I guess, day-to-day basis at work, there's not too much. that you would really do differently. It doesn't get in the way. If you feel comfortable with the people you work around, you can always tell them that you have that pump, and usually they won't ask too much. If they're curious, maybe they'll ask a couple questions, but it's really up to you if you want to answer that or not. The only other thing is the pump makes a noise whenever it runs, or whenever it's infusing. Sometimes people catch that and they'll question why they keep hearing this noise. And again, it's really up to you if you want to address it or not.
Great, thank you. Thank you again for sharing. Look, we've got time for one more question. This one, again, I'll probably hand over to you, Dr. Feenstra, Dr. Trotter and Kerry Lee. This person has asked, is there potentially a way to produce a protocol that all hospitals have to treat people with IV pump medication? Any thoughts around that that you might be able to share with us?
I think what I'd say is it's very easy to write protocols, but most hospitals don't see patients on intravenous epoprostenol very often. So when a patient comes in, there oftentimes won't be forewarning. And to actually get the protocol out and read it in that moment of crisis, when they need something urgently doing or need looking after, I think that's a barrier. So we can write protocols and we can advise and we can contact medical staff and other hospitals when our patients come in, and we can write the protocols, but whether they're helpful, I guess that's the main question I'd have. Just in that moment of panic, you've got to realise that the piece of paper is there to actually dig out and look at.
So we're fortunate enough that at the Prince Charles Hospital, because we're attached to the transplant service, that there's always a physician on call to be able to answer questions from other hospitals. And also, if patients do present here after hours, our nursing staff in the thoracic ward have been skilled up to be able to deal with and give advice and assist patients with pump issues or the emergency department, and also assist other hospitals if they have questions.
I think that's it. It's partly asking our patients when they present to so-called foreign hospitals, if you like, that there's help and experience and doctors who can advise them what to do. And that's probably the best course of action. Say, I've got a serious medical problem, this pump's essential for me. Can you contact my local hospital to get further advice if you're not sure?
And Kerry's done a lot of work with the Queensland Ambulance Service here about patients on IV epoprostenol are identified when the Queensland Ambulance Services call to a patient that is on IV epoprostenol, and there are protocols for the ambulance officers to follow, particularly if there's a line issue, getting a peripheral line in and then starting a patient's infusion through that peripheral line till they can get to their nearest hospital if it's not not the Prince Charles.
Okay, thank you so much, and hopefully that was helpfor that person that asked the question. They did have a little follow-up where they suggested perhaps education for all hospitals, and you did touch a little bit on that with when people do present at hospitals, and then connecting them with their treating healthcare team in hospital. So look, thank you for answering those questions. So we do have a couple of, we've got one more question that's come through. It looks like it is quite a specific question around someone's local ambulance service not being informed about Hickman lines. Would there be any guidance that you could share with someone if they're wanting to confirm about what their ambulance service knows and doesn't know, or any guidance there that you might be able to offer?
I can address this one. Probably, if I'm not quite sure what the other states and territories do in regards to liaising with their emergency services for people that are in that area that are on intravenous epoprostenol. I know from our experience here in Queensland and with our patients that we have in northern New South Wales, We regularly update them in regards to our patient group and cohort, and also when there's changes, additions, or patients have a change of address, and reassuringly that is identified on the ambulance system here, that if a call comes from that location, then on the system here, they have a copy of what we call our safety letter that we provide to our group of patients, and that safety letter is an exact copy of what the patient carries with them and holds with them as a reference point. So in the event of something happening with their continuous infusion, whether it's to do with a intravenous line failure or a pump failure, that the ambulance service knows exactly the protocol to follow, and that's what the patient will be guiding them to do as well. So I'm not quite sure whether the question is from somebody in Queensland. If it is, then I'm just reassure that we've communicated to all of our patients in regards to Queensland Ambulance Service being very aware and having on the system that that they are a person that resides at home with a continuous intravenous medication infusion that can't be interrupted, and there's a protocol to follow in the event that something happens to that. But I can't speak to what happens in other states, but if the question does come from somebody in another state, I suggest talking to your PH nurses and asking what their liaison is with the emergency services around their notification of the Hickman line or the continuous infusion.
All right, thank you. Look, that was great to have so many questions come through for both of you, and really highlights how how many members of our community do have questions, and no doubt all of you who asked those various questions would have been helping other people who are thinking the similar things or experiencing similar situations. So, thank you for taking that time to submit those questions, and thank you to our speakers for addressing those. If anyone does have any additional questions around their PAH, managing their lung health, please do contact our Information and Support Centre. So there is a free call number there available. So if you do have questions for yourself or for your loved one, please do connect in with us. The team can provide you with further guidance and connect you with key resources that may be helpful for you. We can also connect you in with our various peer support programs. So Kerry Lee was mentioning how having that support and knowing that you're not alone can be really, really helpful. So we are very pleased to announce that we do have a dedicated PAH support group, and that is available for people across Australia. So those questions that we had coming through around coping with practical things such as showering and going to work, or coping with the different questions that you hear from people in your workplace or people on the street, it's an opportunity to come together in that support group and share those stories with each other, and as Tharuka did today, provide words of wisdom and stories of hope as well as to how you can manage some of those challenges. So please do reach out if you do want some additional support, and we'll certainly provide you with further guidance and can connect you in with our peer support program. So thank you to everyone for joining today. Thank you again to our speakers. Really appreciate you taking that time to come today. It's been fantastic to have you all in this one virtual room with us. And please do take care of yourselves and each other, and we'll see you at the next webinar. Thank you.